Wolf. Okay. Um, I guess we should start. All right. All right. I'm going to share my screen. How's that look? Good? All right. All right. So welcome to our SSCD webinar tonight. We're going to be going over the best of Digestive Disease Week 2026. And our speakers today are myself, Sharon Weston, Telly Chung, Andrew Ford, Vahe Badalian, and Amelie Therian. And our agenda will include going over some highlights of DDW abstracts, and then we will have an opportunity for questions and answers. And so we'll go ahead and get started. I'm going to start off with our first poster. This was done by Erin Reiger from the Celiac Disease Center at Columbia University, and she shared her research on patterns of use of common gluten detection devices in the abstract titled Predictors of Patient Use of Gluten Testing Technology in Celiac Disease, a Cross-Sectional Survey. And so just a little background, we know that unintentional gluten exposure is a frequent cause of persistent symptoms in celiac disease. There are commercially available gluten testing technologies that can test food and stool and urine for either gluten or gluten immunogenic peptides. There's limited research on real-world patient awareness and also the use of these technologies. And so their aims were to explore awareness and attitudes and practices regarding gluten testing technology among adults with celiac disease. And they estimated the proportion of adults with celiac disease who have ever used a gluten testing technology. And then they identified some characteristics that were associated with the use of these different technologies. Their methods included a cross-sectional electronic survey of adults with biopsy-confirmed celiac disease who were following a gluten-free diet and were at least 18 years old. They were recruited from the Columbia Celiac Disease Center listserv. This was done last summer from June until August. And the survey included a variety of questions looking at demographics and disease history, symptom burden, celiac disease management, and also questions related to the use of the gluten testing technology that assessed awareness, attitudes, and practices. And then they did some statistics. And so results of 400 respondents, 64% were aware of gluten testing technology. The most frequently used technologies were NEMA, and then Easy Gluten, and then Gluten Detect Stool and Urine were the other ones. And then of those that reported just where they got their information from, the top sources were really social media and then product advertising. And with regards to utilization, among the 254 participants that were aware of the gluten testing technology, about 18% reported that they either were a current user or they formerly had used this technology, but only about once a month or even less than once a month. The reasons why they didn't use it were mostly because of either concerns of accuracy or cost, or perception that the technology was just not helpful or necessary, and also lack of physician recommendations. And so in conclusion, the awareness of gluten testing technology was common, but only 1 in 5 participants had ever used it. Technology users were generally younger, they were more symptomatic, and more likely to engage in repeated dietitian follow-up as well. And so participants experiencing persistent symptoms may be turning to gluten testing technology alongside specialized dietitian care as just one of several strategies to manage their symptoms. The next abstract that I'd like to present that was a poster at DDW was done by Lillian Caldwell, one of the SSCD Fireside mentees, and she presented research findings that highlighted a need for more nutrition education for adolescents with celiac disease, just to encourage more nutrient-dense gluten-free choices and appropriate follow-up care. And in her abstract titled Unpacking the Gluten-Free Diet, Ultra-Processed Food Intake, and Fat Mass in Adolescents with Celiac Disease, was very interesting. She looked at a lot of different parameters that had to do with the type of food that our adolescents are eating, and also investigated anthropometrics. And so, as an introduction, ultra-processed foods are industrial formulations with additives that improve shelf life and palatability. They make up 63% of the pediatric diet based on NHANES surveys. They are under increased investigation for associations with cancer, obesity, and cardiometabolic disease. And children with celiac disease may be especially vulnerable to ultra-processed food consumption just due to the processing needed to make gluten-free food. So they examined whether ultra-processed foods are more prevalent in the gluten-free diet, and if intake is related to body composition changes in adolescents with celiac disease. So their methods included 12 to 18-year-olds with biopsy-confirmed celiac disease who were following gluten-free diet for at least 6 months. They were recruited from GI clinics. They did bioelectrical impedance analysis to measure body composition regarding fat mass and fat-free mass. They also performed 24-hour diet recalls to identify food consumption, and also included NOVA food classification to identify which foods were ultra-processed. And so of the results, they found that there was not an association between ultra-processed food intake and fat mass in adolescents after controlling for age and sex, but they did find that there was actually a significantly lower intake of calories from ultra-processed food in the celiac disease cohort as compared to NHANES data for 12 to 18-year-olds. And results also indicated that there were 5 participants that had accidental exposure to gluten. And so their conclusions were that, first of all, ultra-processed food intake was not associated with fat mass percentage changes in pediatric celiac disease after controlling for age and sex with regards to ultra-processed food consumption. Also, they found that ultra-processed food intake was lower in the Boston Children's Hospital celiac cohort compared to NHANES surveys for general pediatric population. And then they also found that food containing gluten were identified in 5 of the 24-hour recalls, highlighting the potential need for more frequent dietitian follow-up. They also found that the percent calorie intake from fat was exceeding the recommended dietary allowance of 25 to 35% from calories. And that also suggested a need for more nutrition follow-up regarding appropriate fat intake on a gluten-free diet. And further analysis controlling for additional factors such as physical activity may also help clarify these relationships. The third poster I'd like to present was titled Creating Celiac-Friendly Schools, Enhancing Environments for Children's Health. And just a little background on this abstract, we know that celiac disease and strict adherence is the only effective treatment, but maintaining a gluten-free diet is especially difficult for children in school settings. This study really looked at the availability of safe gluten-free food, gluten-free diet adherence, and measures of celiac disease-specific quality of life survey results in school settings among students with celiac disease. And so students in this study were in the Stanford Children's Health schools, and so they were ages 4 to 17. They had a confirmed diagnosis of celiac disease, and surveys assessed quality of life indicators, and then quantitative analysis included descriptive statistics, and the focus groups are still ongoing. And the participant characteristics included 99 students, about half of them were female, and 87 of those students attended schools where food was provided. So of the key findings, the first key findings had to do with limited, safe, gluten-free food availability. And so among the students that were attending schools where food is provided, 62% reported poor or non-existent safe gluten-free food options. Among public school students, 43% reported non-existent safe gluten-free food options. And the takeaway was that safe gluten-free food access in schools remains a major barrier to follow the gluten-free diet. The second key finding had to do with gluten-free diet non-adherence. And among students attending schools where food is provided, 49% were considered non-adherent to the gluten-free diet. This included food sharing, intentional gluten exposure, accidental gluten exposure, and the clinical concern here was that nearly half of the students experienced challenges maintaining strict adherence in school settings. And the third key finding had to do with quality of life and adherence, and students who were adherent to the gluten-free diet had significantly higher quality of life scores, and the interpretation there was better dietary adherence is associated with improved celiac disease-specific quality of life. And so the clinical implications of this poster were that schools play a major role in celiac disease management, and the findings highlighted a need for improved school meal accommodations, better gluten-free food safety practices, staff education on cross-contact prevention, and increased awareness of celiac disease. And opportunities for dietitians included providing school guidance letters, educating families and school staff, supporting 504 accommodations, and advocating for safe school meal practices. So the key takeaways were safe gluten-free food access in schools is often inadequate. Approximately half of the students reported non-adherence, and better adherence is associated with improved quality of life, and schools are critical partners in pediatric celiac disease management. And then the last two posters I'd like to present both had to do with the use of GLP-1s in adults with celiac disease. The first study I'd like to present was done by Sarpong Boateng and colleagues from Yale University, and this looked at clinical outcomes of GLP-1 use in adults with celiac disease, and this was a propensity matched cohort study. And so just a little background information, GLP-1s are widely used for obesity and type 2 diabetes, and many patients with these conditions also have celiac disease. However, the impact of GLP-1 therapy in these patients with celiac disease beyond glycemic control and weight loss really remains poorly understood. And so this team aimed to evaluate the cardiometabolic, nutritional, and psychological effects of GLP-1 use in adults with celiac disease and coexisting obesity or type 2 diabetes. And so this was a retrospective cohort study. This used the TriNetX US collaborative network, and they identified adults 18 years or older with celiac disease who also had coexisting obesity or type 2 diabetes. Then they were stratified into two cohorts, individuals with celiac disease without GLP-1 usage or with GLP-1 usage. And then propensity score matching was done. They looked at demographics, comorbidities, medications, and lab variables to ensure baseline characteristics were balanced. And so the primary outcome was all-cause mortality. Secondary outcomes included diarrhea and malabsorption symptoms, fat-soluble vitamin deficiencies, iron deficiency anemia, neuropathy, depression, and anxiety. And the results found that after propensity score matching, this was a huge study, 11,192 patients were included, 5,596 in each cohort. And the GLP-1 users had an 86% lower risk of death during the 1-year follow-up period compared with non-users, with improved GI, hematologic, and mental health outcomes. The GLP-1 users demonstrated a higher risk of fat-soluble vitamin deficiencies, however. So in conclusion, adults with celiac disease and coexisting obesity or type 2, GLP-1 usage was associated with substantially lower risks of all-cause mortality, iron deficiency anemia, malabsorption symptoms, and depression, but it did increase the risk of fat-soluble vitamin deficiencies. And then the last poster I'd like to present also having to do with GLP-1 usage was done by Dr. Muhammad Ali, Ibrahim Kazi, and colleagues, and this was titled Impact of GLP-1s on Clinical Outcomes in Adults with Celiac Disease, a multi-institutional cohort study. This team pointed out that use of GLP-1s have established metabolic and anti-inflammatory benefits and GI motility effects, and their potential influence on disease-related outcomes in patients with celiac disease remains unclear. And so their aim was to investigate the impact of GLP-1 therapy on outcomes in this multi-institutional cohort. They also used the same network as the previous study, the TriNet X Global Research Network, to do their retrospective cohort study of adults with celiac disease that were treated with GLP-1s. And they also looked at demographics, major comorbidities, and anti-diabetic medications. And what they found was that GLP-1 use was associated with significantly lower risks of multiple complications related to celiac disease, including microscopic colitis, exocrine pancreatic insufficiency, iron deficiency anemia, malnutrition, dermatitis herpetiformis, and osteoporosis. No differences were observed in the risk of enteropathy-associated T-cell lymphoma, and GLP users demonstrated higher risks of reflux disease, MASLD, and type 1 diabetes. And so, in conclusion, GLP-1 therapy in adults with celiac disease was associated with significant reduced risks of key malabsorptive and autoimmune complications, but GLP-1 use correlated with higher rates of reflux, MASLD, and type 1 diabetes diagnosis. And so these findings really highlight the complex interplay between the use of GLP-1s and celiac disease and warrant more prospective validation. And so I'm now going to just pass it on to Telly Chung. Thank you.
Great, thank you, Sharon. Let me share my slides. Okay, that looks okay. Looks good. Okay, great. Thanks, Sharon. Thanks for those here and those eventually that will join us for this webinar. My name is Telly Chung. I'm a Peds GI provider at UCSF. What I'll try to highlight today are 4 abstracts and posters that came out of this DDW talk, among many that you'll hear today. So the first I have here is called Risk of Solid Organ Transplantation in Individuals with Celiac Disease, a nationwide cohort study. This is a study presented in the Clinical Insights in Celiac Disease session at DDW. And what it aimed to do was to measure the risk of solid organ transplantation in individuals with celiac disease. I'm a pediatric GI provider, and in my conversations with patients, often we talk about morbidity, mortality, diet, symptoms, socioeconomic burden, short stature, growth failure, and the list goes on. Solid organ transplantation is not something I always think about as a pediatric gastroenterologist, and it may blend into our adult for our patients that had eventually become adults with celiac disease. So this is a study that was of interest for me. What this study did was it was a population-based matched cohort study of about 41,000 individuals with celiac disease that had biopsy-proven findings found between 2000 to 2023. They used a nationwide cohort through the Espresso Swedish cohort, and this takes, at least based on studies available in 2019, about 2.1 million individuals at that time. 7 years later, I expect that number to have risen. Of this cohort, they matched the 41,277 individuals with 5 controls. So effectively, this is a nested case control study, and I thought it would be a neat way to look at something that might not be very common, which is solid organ transplantation. Here is a table 1 that looks at some of the basic characteristics of this group. And on the left column are those individuals with celiac disease. On the right column are individuals who are matched to compare with celiac disease. And what we have here are age, sociodemographic factors. What's of note, and hopefully is not surprising, is that compared to controls, these individuals with celiac disease had more cases of type 1 diabetes, autoimmune thyroid disease, IBD, as well as non-celiac disease, autoimmune disease, anything from 3 to maybe more than 10-fold increased. And again, that's something we do expect to see as a higher risk of associated conditions in celiac disease. The core findings from this abstract looked at, again, the risk of solid organ transplantation. It's a very busy slide, so I'll try to highlight a few points that stood out to me. So again, we're looking at those with celiac disease and those with our comparators. Among those that had solid organ transplant, if we look at the proportion, about 2.1% of those patients with celiac disease had solid organ transplants, and among our controls, 0.6%. If we look at our incidence rate, or effectively new cases, comparing those with celiac disease and our controls, there's about 3 or 4-fold increased risk of having new diagnosis of organ or new need for a solid organ transplantation among our patients with celiac disease. And then lastly, when they looked at the hazard ratio, or effectively hazard of having an organ transplant, when they adjusted for age, sex, county, as well as calendar period, there was about a 3.8-fold increase in the hazard risk of having solid organ transplantation when they accommodated additional factors such as education, non-celiac disease, autoimmune disease, as well as outpatient healthcare visits. They concluded at a hazard ratio of 2.8 effectively. So to summarize, individuals with celiac disease seem to have a 3 to 4-fold increased incidence rate of having organ transplantation at about 2.8 increased hazard ratio. Other things that stood out to me from this table were, if you look at the blue arrow for males, there's about a 5.6 increased hazard for transplant. Among our patients 18 to less than 40 years old, about a 3.5 increased hazard. And among those very old, greater than or equal to 60, about a 6.6 increased in hazard. Other things of note were individuals with less than or equal to 9 years of education had a 17-fold increase in their hazard. Takeaway from this is that, at least for me as a pediatric gastroenterologist, increased risk of celiac disease, increased risk of solid organ transplantation among our patients with celiac disease. Another study that was of interest from DDW was assessing histologic change in serial celiac duodenal biopsies using routine pathology practices, factors affecting accuracy, and inter-observer reliability. This is a study that came out of UT Southwestern, led by Dr. Robert at Yale. And this is effectively a thought experiment where they took about 10 pathologists from 10 academic centers and asked them the question, can you tell, or how much of a difference can you see comparing two duodenal biopsies? And their goal was to find the minimal detectable difference in the villus height to crypt depth ratio perceived by pathologists. As we think about clinical trials and drugs, this does become important, as that histologic endpoint we look at will depend on pathologists and their ability to tell the difference between their diagnostic and then future follow-up biopsies. Here is a figure. If we look on the right side for duodenal mucosa in celiac disease, the study looked at, they asked pathologists, they gave pathologists a pair of duodenal biopsies, A and B, and they asked them which one has more enteropathy, and they characterized some of these results. So again, 10 pathologists out of 10 academic centers, 20 pairs of duodenal biopsies, and they compared it relative to the gold standard, or effectively what was measured initially based on these pathology reports. There's a bit of training that these pathologists had. And again, they were told, given this pair, which one has more enteropathy or no difference? This is a relatively busy figure as well. To break it down, if we look at the left column and the x-axis, looking again, biopsy A versus biopsy B, and the difference in their villus height to crypt depth ratio, there's an absolute difference between 0 to up to -3. They use negatives for this difference. And if we look at the y-axis, again, there's 10 pathologists, so up to 10 correct, and there's 20 dots, or 20 pairs of biopsies. And on the right column is, I believe they didn't explicitly say, but it looks like a ratio, again, A and B ratio of their intraepithelial lymphocytes. If we look at the blue lines, anything close to 0 for the absolute difference or close to 1 for the relative difference means there's minimal or no difference. And what they conclude from this is that more than or equal to 8 of these pathologists correctly identified greater enteropathy in only 60%, or 12 out of 20 of these biopsy pairs. So majority identified kind of a little bit more than flip up a coin. So in my general impression, not fantastic, right? They did note that small differences in villus height to crypt depth ratio were significantly associated with fewer correct responses. And I believe that is identifying these areas circled. Again, closer to those blue lines, there's a less difference between A and B biopsies, and hence a greater difficulty in identifying difference. They did allow these pathologists to comment on what they found in their findings. And what they described was that among those equivocal villus height crypt depth pairs, pathologists use intraepithelial lymphocytes to select biopsies of greater enteropathy. Takeaway is that small differences in these villus height crypt depth ratios increase the challenge of identifying enteropathy, and that may be confounded as well by IEL density. Briefly, this is a study that came out of Columbia by our team with Dr. Lebelwall, led by Dr. Anil. This is disability and healthcare interactions in patients with celiac disease in the United States, an analysis of All of Us cohort. So the All of Us cohort is a national level database of voluntarily provided individual data. This team took that data, identified our patients with celiac disease, and asked what was their healthcare access and interactions. This is a older figure, courtesy of Dr. Kong. You can ignore the data in the middle, but effectively, again, they're looking at EHR data, surveys, genomic data, blood pressure measurements, et cetera. And what they looked at using, also similar to our first study, 1-to-5 matching, so one patient with celiac disease relative to 5 controls. They matched them based on age, sex, ethnicity, and genetic similarity. And they looked at 5 categories in their survey: basic, lifestyle, overall health, social factors of health, healthcare access and utilization. And in this table, they summarized a few features. They found that individuals with celiac disease compared to controls are more likely to report fatigue, more frequent specialty visits greater than equal to 13 per year, negative interactions with healthcare, and most surprising, feeling less respected by practitioners, which is concerning, I think. Of note, again, this identifies there's about 19% increase in the odds of having fatigue among our population with celiac disease, and about a 10% increase in the odds of that feeling of not feeling respected. I think the takeaway from the study is that we do need to underscore the need for a multidisciplinary approach that integrates patient-reported experiences into clinical management. Lastly, this study came out of our team from Columbia as well with Dr. Wolf, led by Dr. Carrieri. It's labeled How Students with Celiac Disease Navigate Their Transition to College, the Impact of Early College Experiences on Gluten-Free Diet Adherence and Quality of Life. So this study aimed to understand the experience of students with celiac disease transitioning to college. Novelty is that this is a mixed method study, so there's qualitative data in addition to quantitative data. They identify 15 individuals with biopsy-proven celiac disease on a gluten-free diet, living on campus, and completed 3 semi-structured interviews with them over a 4-month period during their first half of college. And they assessed their dietary adherence, symptoms, quality of life, and psychosocial factors. This is a table that describes their preparation for college. So among this population, 15 students asked, majority didn't quite seek their celiac disease center for help, an advertisement in the setting of going to college. Majority didn't reach out to their Office of Disabilities prior to college. Just a slight over majority, 53%, did reach out to their dining services. Majority did not reach out to their residential life or Office of Residential Life, and also majority did not ultimately request accommodations in college. Takeaway meaning a few students took proactive steps to manage gluten-free diet in college. With that said, what this study described is that a majority did maintain good dietary adherence and adequate quality of life. The last slide I have here is the summary from this work. And effectively, they look at facilitators and barriers to the college experience, ultimately to promote gluten-free diet adherence and quality of life, or as a barrier to those. Here's a summary of some of those things that came out of the study, including facilitators included personalized dorm room strategies, dedicated gluten-free dining hall, college-specific dining apps, support of parents and peers, self-advocacy and self-efficacy. Barriers included cross-contact, restrictive allergy-free stations, lack of staff training and options, mandatory meal plans, shared kitchens, and decreased motivation to eat. The study was nice in that it identified multiple factors and levels in the environment, community, and individual levels that could be an area of intervention. I'd like to introduce Andrew for doing the next part of our talk.
Thank you so much, Dr. Chung. Yes, I'm Andrew Ford, and I am an adult gastroenterologist who will be starting at the Cleveland Clinic Celiac Disease Center very shortly here. But without further ado, I have two very interesting posters that I'd like to share with you guys. Let's see, just bringing my screen up here. All right. Okay. So the first study I'd like to share is this interesting systematic review and meta-analysis that came out of Aurora Health in Wisconsin that looked at the diagnostic yield of double balloon enteroscopy in celiac disease patients with persistent symptoms. So I thought this is a very interesting one, as double balloon enteroscopy is a very specialized procedure that I actually do myself, and we don't use it all the time, but it's very useful when you do have need for it. And looking at what they sought to look for in the study, persistent symptoms can occur in up to about 20% of celiac disease patients. Of course, most often this is from inadvertent gluten exposure, but sometimes, rarely actually, they can be indicative of severe complications such as refractory celiac disease, and sequelae such as ulcerative gingivititis, and heaven forbid, enteropathy associated T-cell lymphoma. Double balloon enteroscopy, as we've established, is a niche procedure that can evaluate the deeper small bowel, and in certain situations can be very useful with these complicated celiac disease cases. And what these authors sought to do was to evaluate the diagnostic yield of double balloon enteroscopy for this population. How they did this was by looking at a variety of databases such as PubMed, Scopus, Web of Science, and they use terms such as double balloon enteroscopy coupled with refractory celiac disease, persistent celiac disease, diagnostic yield, and so forth. Their inclusion criteria for studies included those that were prospective and retrospective that reported the diagnostic yield of this procedure in identifying complications such as malignancy, ulcerative gingivititis, refractory celiac disease itself, in adult patients, so those greater than or equal to 18 years. And these are people with persistent symptoms post gluten-free diet. They excluded any non-English studies, pediatric cohorts, or without extractable data. They also did a subgroup analysis in those who, those who had refractory celiac disease versus not. So when they got to it, the results showed that from 1,203 screened records, seven studies met the criteria. This led to about 393 patients, 76 of whom underwent double balloon enteroscopy. There are four retrospective studies, as well as excuse me, three prospective. These were all at single center except for one multi-center. The indications were refractory celiac disease in four of the studies, whereas suspected complicated celiac disease in three. The pooled diagnostic yield for any complications, so this is refractory celiac disease, ulcerative gingivititis, malignancy, any of them, it was 27.77%. And it was a fairly high heterogeneity, all things considered. For malignancy specifically, it was a lower diagnostic yield, pooled at about 8.7, with the confidence interval hitting 0. High heterogeneity there as well. And then for ulcerative ileitis, it was about mid-tier, 16.6. Seems I was muted there for a second. Sorry. Excuse me. Yeah, ulcerative ileitis, 16.7, and lower heterogeneity in comparison. The subgroup analysis did show that there is a higher diagnostic yield when refractory celiac disease was known. For any of the complications versus those who did not have refractory celiac disease. Also worth noting, because it's a more invasive procedure, the adverse events reported were just minor. They were minor bleeding, though there was, I believe, one perforation in the studies included. There was a moderate risk of bias that's worth noting. And then just to show here is this forest plot. You'll see that any complication comes to this pooled of 27.7, and we see that we hit the 0 mark for malignancy specifically, and ulcerative colitis again at 16.7%. So the authors concluded that double balloon enteroscopy is effective for detecting complications in high risk persistent celiac disease. And interestingly, they also note favoring sequential use with capsule endoscopy, because typically that would be the approach in this patient population, is that you would start with the non-invasive capsule endoscopy. I'd be curious to know how they treated capsule endoscopy in the studies that they looked at, but it wasn't quite clear from the poster how they did. But still, an interesting finding, and again, highlights the need for this procedure in certain high-risk scenarios where we don't get the answers right away from the initial workup. Another study, and I think that this one really caught my eye as far as posters go, is the validation of ICD-9 and 10 codes for celiac disease. And this was a joint effort out of the National Capital Consortium by Dr. Huang, as well as some colleagues from Mayo Clinic. I see Dr. Murray there, for instance. But we all know celiac disease gluten is a gluten-sensitive enteropathy, but um, there is a big concern in these large database studies where you don't have access to histopathology and validated records, where we rely on ICD 10, 9, and 10 codes. This validity has been in question. A side note is that some earlier work suggested a sensitivity specificity in the 90% for 2 times documented ICD codes, but other than that, it was a fairly skim research body prior to the study. So they sought to use a little bit different of an approach to validate ICD-9 and 10 codes for identifying celiac disease patients by themselves. They did a retrospective cohort study of active component service members in the Defense Medical Surveillance System, DMSS, and this spanned about 35 years. Individuals with greater than or equal to 2 medical encounters coded with ICD-9 for celiac disease or the ICD-10 code for celiac disease were identified. So again, similar to that previously identified threshold. Manual chart review then was done to confirm the celiac disease diagnosis, and they did that based on positive serologic tests coupled with the pathology documentation by a gastroenterology specialist. They use that then to calculate the positive predictive value. Among 1,269 adjudicated charts, 294 lacked available data for review. They were excluded from the final calculations. But of the 975 charts remaining, 639 were confirmed as true celiac disease cases and 336 were false positives. The calculated positive predictive value then was 65.5%. And there's a pie chart just to underscore that positive predictive value. But suffice it to say that that isn't the mark that we would want to hit to be relying on solely the ICD-10 or 9 codes for that matter. So when using these large databases, which are such powerful tools and provide us such compelling numbers and findings and really kind of facilitate some interesting research, we do have to be cautious because if we use solely the ICD codes, it looks like we could be including a lot of people who may not actually have celiac disease. So the authors rightly state that this does underscore the need to refine coding strategies to further improve diagnostic accuracy, and in turn, that would help identification of these patients in the larger database studies. And it looks like they would like to kind of build this into future research, try to explore biomarkers from the Department of Defense Serum Repository to assess their diagnostic yield and accuracy. So, um, really interesting finding among a lot of the database research we see. Really impressed by this study. But without further ado, I'd like to introduce my colleague, Dr. Badalian.
Thank you very much, Dr. Ford. I'm Vahe Badalian, pediatric gastroenterologist from Children's National in Washington, D.C., and I'll be presenting three posters today. Let me just share my screen. If we can maybe unshare Dr. Ford's, and then I can start sharing mine. Okay. Okay, great. So the first poster that I'd like to discuss today is from Celiac Foundation and International Society of Studying Celiac Disease, ISSCD. This is led by Libby Arnett and colleagues. So this one is not so much about the pathophysiology of celiac disease, but more about the practical reality of therapeutic development. We have more investigational agents in celiac disease that are in the pipeline, but we're still facing a major bottleneck, which is finding, enrolling, and retaining the right patients. So this is a recurring challenge because patients require to be on a gluten challenge, gluten exposure. For many patients, this is a major psychological and also physical problem, especially after so many years that they may have been working to stay on a gluten-free diet. So the investigators in this project aim to understand from the site perspective, from the researcher perspective, what are the barriers? What kind of barriers interfere with the recruitment and retention in celiac disease clinical trials? And then what strategies may improve the enrollment of the patients? So this was a mixed method study. Let me see if I can advance my slides. And essentially, the investigators recruited 10 principal investigators and 10 site coordinators across the U.S. research sites that were experienced in celiac trials. And they used the Celiac Disease Foundation's iQualify Celiac platform that is used for recruitment of the patients for drug trials. So they looked at different themes expressed by the investigators as well as the research coordinators. As you can see, there was quite a bit of experience among the respondents in running trials, and essentially the responses were sort of tabulated and grouped into different themes. This slide shows sort of the most recurring themes, and you can see that the gluten challenge was the most frequently reported barrier as discussed by the principal investigators. And again, that's not surprising because people experience a lot of symptoms with this. The anxiety also could be one of them as well. The other major barriers included restrictive eligibility criteria, as well as logistical burdens such as travel or time commitment, or even delay in obtaining the outside records. The coordinators emphasized also logistical issues. In terms of the methods or tactics to use to improve recruitment and retention of the patients, the coordinators mentioned multiple ways of contacting the patients and also initiating the contact very quickly after the person is indicating their willingness to take part in a study. The item number 3 here shows that the coordinators have been contacting potential subjects using email, SMS, phone, and they're tailoring and adjusting their strategies by the age group and participant preference. One key factor in helping the investigators recruit the patients was the fact that they were being referred from the Celiac Disease Foundation. So again, the platform that Celiac Disease Foundation has is extremely useful to funnel more patients into these drug trials. The key takeaway is that the recruitment is not just a patient motivation problem, it's also an infrastructure problem that has to do with contacting, getting records, and how timely you do that. But I think that this is certainly an interesting project, and certainly explains from the perspective of the researchers what are the barriers, but it'll be also very interesting to hear the perspective of the patients as well. The next project that I'd like to present is coming from Boston Children's, as well as the Bet Israel Hospital. This is led by Dr. Sanchez Quines and colleagues. As we know that social determinants of health play a big role when it comes to screening and diagnosing celiac disease, and white patients are disproportionately represented among the patients with celiac disease. So the investigators here were attempting to find out the community engagement and the feasibility of at-home celiac screening using capillary blood collection among Latino population, which again is potentially having there can be potential higher rates of folks that have difficulties accessing the healthcare system. Can we bring the screening for celiac disease closer to the patient by doing the at-home testing? The investigators used a prospective method. So they first selected the zip codes in the Boston area that were underserved or low income. And then the adults that were linked to the medical records, electronic medical records of these institutions, were sent letters both in English and Spanish with a QR code linking that to the online screening questionnaire in the participant's preferred language. So the questionnaire had to do with symptoms and other characteristics. And then once the patient completed the questionnaire, then if they were eligible, they were mailed a blood collection kit and instructions on how to collect the 500 cc microliter tubes, 2 of those tubes, under the virtual supervision from somebody from the hospital. Then the samples were shipped and processed and analyzed for the celiac antibody, which is the TTG-IgA. The study basically is excluded people that already had celiac disease diagnosis or were on a gluten-free diet, or if the patient had prior TTG testing or upper endoscopy over the last 5 years, as well as patients that had difficulties with the sight of blood or had some easy bleeding. This slide shows that the initial round of this project included sending almost 1,300 invitation letters, 700 of which were sent to Latino recipients, and almost 500 to non-Hispanic white controls. When it comes to the rates of return or rates of completion of the questionnaire, investigators found that the rates were fairly similar between the Latino group and non-Hispanic white controls. There was also, the rates were also equal between the gender. Interestingly, among the age group 55 to 64, there seemed to be higher engagement among the Latino group, which is somewhat difficult, or I don't necessarily have a good explanation for this at the moment. This one shows the flow chart again, sending invitation letters, how many of them resulted into completed surveys, and then of those surveys that were completed, how many patients were eligible even to receive a blood collection kit at home, and then how many actually attempted to do the collection of the blood, and how many were successfully able to collect the blood and then send it back for it to be analyzed. So you can see that the numbers start very large, but throughout this sequence of these events, the numbers go down very quickly. So in the end, the the number of the samples that were analyzed were 8 out of roughly about 2,000 patients. So certainly the rate, it seems to be very small, but this was a proof of concept study to demonstrate both the engagement of the community in the underserved areas, as well as the sort of a technical ability of people to collect and properly collect and send the sample back to be analyzed. So I think that this perhaps if the methods get simplified, blood collection methods get simplified, maybe this approach will be expanded again in the future to again access people that have difficulties so related to social determinants of health being screened for celiac disease. And then the last poster that I like to show is coming from Colorado. This is led Colorado Children's, led by Dr. Stahl and colleagues. And this is about the islet autoimmunity screening for children with celiac disease or children that have a family member with celiac disease. And why is this important? Well, over the last couple of years, a new drug, teplizumab, has been on the market that allows to delay the onset of type 1 diabetes in patients. And as we know, celiac disease and type 1 diabetes, both being autoimmune conditions, are associated with each other. So the investigators here wanted to use the data that they already had from the celiac autoimmunity screening for kids and or ASK study in Colorado to find out the rate of the positive antibodies among this screened population. The number of the patients for whom their celiac disease status was available in this study was about 31,000 patients. And essentially, majority of these patients had no celiac disease. About 340 of these screen patients did have celiac disease, and about 1,200 patients did not have a celiac disease but had a family member with celiac disease. So they looked at the blood samples for these patients to see how many of them had positive antibodies for diabetes. They ran 4 different antibodies: GAD, islet antibody 2, insulin, and zinc T8 antibodies. And essentially what the investigators found is that in the cases of patients that had known celiac disease, 5 out of 300, roughly about 1.5%, did have multiple anti-islet antibodies, and they were successfully referred to the endocrine specialist for further monitoring and whatnot. And then for among the patients with family history, even if they did not themselves have celiac disease, interestingly, 1.7% of these patients also did have circulating autoantibodies against the islet cells. So this was an interesting, somewhat interesting and surprising finding. This certainly matters because perhaps this could be looked at it in terms of the public health angle as to whether it's feasible to screen for the autoantibodies and what will be the yield of it, and then what would be the potential risks, costs and the benefits of monitoring these children and perhaps putting some of them on teplizumab to delay the onset of the type 1 diabetes. So a very interesting study. This also creates a counseling challenge, what to do with these patients that now have positive antibodies. How are they going to deal with that news if they already are managing celiac disease or they have a family member that has a celiac disease? So certainly burdens and risks and potential benefits have to be carefully weighed. So I think that that's the last of my slides. So without further ado, I'll introduce Dr. Emily Tyrian to take over the next part.
Thank you. And while I share my slides, I just want to make sure that the audience doesn't have any questions about the prior posters, speakers. Feel free to ask while I'm placing my slide. In fact, I have a question for Vahe. So what is that drug? Like, how does it work to delay type 1 diabetes?
As I recall, it's a monoclonal antibody that binds, if I'm not mistaken, a receptor on T cells, if I'm not mistaken. But I'll check that out. I'll check it out.
That's super interesting. I was not aware that it was like actually used. So okay, so I will quickly present like three poster also. So browsing through the abstracts and posters, I found those two that were kind of like in a sense connected about persisting symptoms on a gluten-free diet. So I'll present both and then like put them a little bit together for a discussion. So the first posters was an analysis from the iCure Celiac Patient Registry that is hosted by Celiac Disease Foundation. So they enrolled patient age over 12 years with a confirmed diagnosis of celiac disease. And they polled patients that had data about the gluten-free diet adherence with the celiac dietary adherence test and the celiac symptoms index for various symptoms in the last 4 weeks. And the outcome of that study was to look at the symptoms in relation to dietary adherence and the productivity, the work, school days missed in relation to the gluten-free diet adherence and the symptoms burden. So if we look at the patient population, so they had over 4,000 patients who responded to all of the questions and were included. Mean age at diagnosis were 35 years old, on a gluten-free diet on average for 8 years, and most of them lived in the United States. What was interesting looking at that population is that almost half of them were declared as self-managing their celiac disease, and their mean days of missed work, schools per year were 15, which was to me quite significant. And on the figure 2, we can see that about half of them waited at least 2 years before having a diagnosis of celiac disease between their first symptoms and the time of diagnosis. And some of them even waited for like 10, 20 years. And these data are similar to what we found in Canada. So looking at the correlation between the symptoms and the dietary adherence, we can see obviously that the better the adherence for the diet, the less symptoms burden. However, there were still like 10% of patients with excellent dietary adherence that were still having a high symptom burden. And on the lower figure, we can see the correlation between the missed days of school, work, and the symptoms and the dietary adherence. So the higher adherence you had to your diet, the lesser days you would miss, with up to 41 days when you were having like a high symptoms burden and a poor dietary adherence. These are the most common symptoms from the Celiac Symptoms Index that participants reported. And as you can see, even if their adherence to the diet was excellent, like the columns I highlighted in red, there was a significant amount of patients who reported having low energy, stomach bloating, physical pain, pain in the upper abdomen, the pit of the stomach rumbling. So even though overall their score with the CSI was like relatively low in terms of like symptoms burden, they still reported a significant amount of like individual symptoms in the last like 4 weeks. So the authors conclude that even among patients who reported being adherent to a gluten-free diet, many reported moderate to high symptoms burden and substantial productivity loss. These results suggest that the gluten-free diet adherence alone may be insufficient to reduce disease burden in patients with celiac disease, particularly among those with high symptoms burden. And before discussing this poster, I want to jump right away to the second one, which was from a group from the Netherlands about symptoms profile compatible with disorders of gut-brain interaction in individuals with celiac disease on a long-term gluten-free diet. So the disorders of gut-brain interaction are the new terminology for what we consider like IBS, functional disorders, and they're all well described in the new Rome 5 that was recently published in Gastroenterology. So essentially, those groups of disorders are characterized by GI symptoms related to any combination of motility disturbance, visceral hypersensitivity, altered mucosal and immune function. So that correlate with celiac disease, intestinal permeability, low-grade activation of mast cells, increased inflammatory cytokine release, altered gut microbiota, and altered central nervous system processing. So they looked at adult member of their Dutch Celiac Society who had a self-report physician-based celiac disease diagnosis based, like for the other cohort, serologies, duodenal biopsies, adhering to a gluten-free diet over 1 year. And they only selected the ones who had optimal dietary adherence with celiac disease adherence lesser than 13. And their controls were Dutch participants from the population-based Rum Foundation Global Epidemiology Study. And they did a bunch of like online surveys with validated questionnaires like the DGBI compatible symptoms profile, where they were kind of like asking them all of the criteria for each of like ROM4 like diagnosis. Non-GI somatic symptoms, psychological distress, health-related quality of life, and the gluten-free diet adherence. And so their cohort included over 1,000 celiac disease subjects and 1,896 controls. 86% of them were diagnosed with serologies and biopsies. 76% of them were on a gluten-free diet for over 5 years, and 95% reported at least 95% adherence for the gluten-free diet during the past year. And interestingly, on the first like figure here, the bars and columns are the celiac disease group. The white ones are the control group. So there was a significant amount of celiac disease patients that were adhering to a gluten-free diet for many years who have symptoms related to those like the DGBI criteria. And it was mostly the bowel DGBI diagnosis that were higher in that population. So looking at the typical like different types of DGBI, again, in the any bowel DGBI, it was mostly the category of irritable bowel syndrome, meaning having some pain, abdominal pain associated with changes with the frequency of stools, consistency of stools, or related to defecation. And also the category with bloating and distension were strikingly higher in the people with celiac disease. And finally, that I cannot really explain, but proctalgia fugax was also like higher. This means having like some bursts of like isolated pain in the rectum that are not caused by other like organic disorders. And they saw a relationship between having like DGBI symptoms and non-GI somatic symptom severity, psychological distress, and a lesser quality of life for mental health and physical health. So more than half of the celiac disease patient adherent to a long-term gluten-free diet fulfill the criteria to have a disorder of the gut-brain interaction, and it was associated with reduced quality of life. And the other concludes that although the roles of persistent celiac disease activities cannot be excluded, these findings suggest that some patients with persistent GI symptoms, despite the long-term gluten-free diet, may benefit from DGBI treatment. So DGBI treatment, depending on the type of disorder, can be like laxative, fibers, low FODMAP diet, rifaximin for the bloating. So depending on the type of like disorder, there's a lot of other like treatment that we can consider. So essentially, those were two large studies, one from North America and one from Europe, that both included subjects on a gluten-free diet for many years with excellent self-reported adherence. However, we do not know if their intestinal mucosa had completely recovered. We don't have data on follow-up like duodenal biopsies. And they were also like, lots of them were kind of like self-managed. And the stomach bloating was very common in both cohorts. It's possible after having had an enteropathy that they had like changes such as SIBO, other food intolerances, constipation, that they did not get like medical evaluation for because they were self like managing their celiac disease. And there could be a concept of post-celiac IBS, increased visceral hypersensitivity after having had an enteropathy, and increased mast cell activation. And with all of that, we really need to be careful with patient selections for clinical trials that are based on like symptoms, because as you know, they may not all be related to gluten exposures. So I think it's another like warning to really well characterize the populations that we are enrolling with persisting symptoms despite a gluten-free diet. And finally, I want to highlight This poster about like longer diagnostic delays in Hispanic patients with celiac disease from Columbia University. So it was a retrospective cohort study of celiac disease patients from 2004 to 2023. The Hispanic patients were identified by self-identification per EMR and matched to non-Hispanic patients by calendar period of first visit. They enrolled 79 Hispanic patients who were matched to 79 non-Hispanic celiac disease patients. And they found that the Hispanic patient had a significantly longer duration of symptoms prior to the diagnosis, 3 years versus 1.5 years. However, a lot of the Hispanic patient had unknown for the duration of symptoms compared to the non-Hispanic patients. And when we look at the data of those population, the Hispanics were more likely to have Medicaid insurance compared to the non-Hispanic and had less Medicare or private insurance. They both have similar clinical presentations. Most diagnosed with serologies and duodenal biopsies in both groups, but they found seronegative celiac disease patients in 6.8% of Hispanic patients compared to 2.6% in the control group. And finally, they found that the adherence to a gluten-free diet was adequate in both groups. I'm sorry, I'm just going to grab another one. So overall, they only had 1 to 7 new diagnoses per year among Latinos at a major celiac center in New York. There were various aspects leading to delays in diagnosis. The fact that most of the Latinos did not have the data about how long were their symptoms, it made me doubt, like, was the medical history less in depth with Hispanic patients compared to non-Hispanic patients? The social determinants, of course, access with insurance will likely play a role in delays in diagnosis. And the other thing that caught my eye is those seronegative celiac disease. They had 5 patients. So if that cohort, 6.8% was seronegative, but they were still caught because of like more digging and more medical evaluation, we can ask ourselves how many were missed over the entire Hispanic population because it was just not suspected because the TTG were negative and no duodenal biopsies were performed because they were suspecting more like H. pylori, gastritis, and stuff like that. So I found that it was interesting that that data about seronegative patients, and we see that also in Afro-American population, a higher rate of seronegative. So celiac disease may present a bit differently depending on those HLA and other factors related to ethnicity. So I don't have the final closing slide. So Sharon, can you help?
I think I can just state, so let's see.
Or I can say with the thank you if you wish, or.
Yeah, so I can say, so we don't have any upcoming webinars planned right now. There are some changes that the webinar committee is going to be going through with SSCD. But I'd like to thank the webinar committee for all the work that they've done. All of the webinars are recorded on the SSCD website. And so with that, I think we will open it up to questions and answers.
So I want to first thank you guys. You've done an awesome job in terms of synthesizing what happened at DDW. So I don't know how you guys did it, but you did a great job. So thank you. Sharon, I have a question for you. I don't know if I heard correctly, but with the GLPs, was there a reduction in dermatitis herpetiformis?
Muted. Yes, I believe so.
How does that happen?
It was a very large population that study that they were looking at, and let me just pull up the slide. That was the
second one, I believe.
Second one, yeah. So I can share my screen again.
I just found that a little bit fascinating and wondering, is that real?
Yeah, so they had lower risk of microscopic colitis, exocrine pancreatic insufficiency, and dermatitis herpetiformis. Yeah. Yeah.
How does that happen? I mean, I don't know, maybe they're onto something.
Yeah, Dr. Vero, I don't quite see that mechanism as clearly. If there
Yeah.
was a step in the middle where reduced intake appetite from GLP-1 receptor agonists, reducing gluten exposure, then to reduction in symptoms from DH, maybe.
So that you're not eating as much gluten. So it's more the exposure than,
As most perceivable by me, I think so.
yeah.
Yeah, I mean, I would kind of think similarly. You know, I think that we're seeing some interesting effects of GLP-1 usage with even reduction in other things that we wouldn't expect. So, not related to celiac disease, but I think there's even like decreased alcohol intake, things like that. So, so it just, you know, decreased intake of maybe accidental gluten exposures or intentional might also be something that relates to that.
Interesting.
Yeah.
I guess you need more studies to see if that truly is where it goes. But
Mm-hmm. Any other questions? All right. Well, I think that we'll conclude this evening then. And thank you for everybody that attended tonight. And again, this will be recorded so you can rewatch it. All right. And
thank you.
thank you, everybody. All right. Have a
Thank you.
good evening.